ahead and jump in because we have a couple of housekeeping items before I turn it over to the panel here. But let's get started here. So in case you are new to Zoom, which I'm sure most of you are not, then you're probably aware by now that you are muted. All participants are currently muted, but we do want to hear from you. So please go ahead and send your questions for the panel into that Q&A box below, and you'll see it says Q&A on it, and that is for you, questions and answers. We welcome your comments and technical difficulties and assorted questions in the chat room. If you'd like, tell us where you're calling in from, anything that comes up during the program, we're happy to help you with in that chat box. But to make sure the questions get to the panelists, please put them in the Q&A box. And we're gonna get to as many as we can. We've got a large panel today and a number of folks joining us, so we'll get through as many as we can. Go to the next slide, please. And a big thank you to Apovida, which is just a fabulous organization. It consists of a number of old friends of EHealth Initiative and the foundation, and we're just so delighted to welcome back. You're going to hear today, this group is doing some really incredible work right now out there in the field, and we're just so delighted to have them here today. So thank you for your generosity. For those of you who are not familiar with the EHealth Initiative, we are a nonprofit celebrating our 20-year anniversary here in Washington, D.C., and we do education, advocacy, and thought leadership all around how you use innovation and technology to improve care. Next slide. And this is just a list of some of the organizations that we work with. We work with executives across the spectrum of healthcare. If you don't see your company's name up there, then I want you to send me a chat message and tell me who you are, because we need to get you involved. We work with payers, providers, labs, consultants, researchers, all different folks who are trying to figure out how to connect and improve care. And this has been a really important year to do that. Next slide. This year, we're focused on 4 key areas: privacy, virtual care, analytics, a lot of work in social determinants of health, and of course, COVID-19, looking at best practices in education and lessons learned, which is what we're focused on today. Next slide. If you weren't with us or haven't figured out what we're doing right now, we're doing a lot of education, and we would love to have you join us. We've got a number of programs coming up in the next week. We'll be looking at APIs and how that's changing the economics of EHR integration. A lot of popularity around this final rule coming up next week. We encourage you to join us for that webinar next week. If you want to know what information blocking and how all that's going to impact you, please feel free to join us for that. We'll be looking at SDOH data and whole person care on the 25th, and looking at patient matching on the 1st. We've also got a pretty significant series right now looking at virtual care in tribal communities. With Native Americans and Alaskan Natives. And if you are working in that field, this is really important right now, particularly with the pandemic. Please reach out to us and let us know, because we're very interested in folks who are concerned and working in that area. And we'd love to have you join us for our executive session on March 24th. Next slide. If you happen to miss this session today, or you think it's so fabulous you want to send along to somebody else, go ahead and click on ehidc.org, and you will be able to see this program after it's recorded today and any other. And feel free to, again, download those, share them, distribute them. We are all about sharing resources and creating a forum for sharing and learning and growth. So it's just a sampling of some of the recent programs that we've had out there. Next slide. And again, Apovida, the webinar today looking at the need for healthcare systems that can learn fast and lessons from COVID. Next slide. And with that, I'm going to turn it over to the fabulous Kat Jersich, who's the senior editor of Healthcare IT News. You guys read her every day, and we are so fortunate to have her today moderating the panel. So Kat, welcome.
Thank you so much, Jen, and thank you everyone for joining us today. As Jen said, I'm the senior editor over at Healthcare IT News, where I cover the whole gamut of innovations in digital healthcare and the latest tools and advancements in healthcare IT. So I'm really excited to have everyone with us today. With me on the panel are Michael Barr, Blackford Middleton, and Christopher J. Tignanelli. Why don't we take a few minutes for you all to introduce yourselves? Michael, why don't you go first?
Hi, Kath. Thanks very much. It's a pleasure to be with all of you today. Michael Barr, the Executive Vice President for Quality Measurement and Research at NCQA. I've been at NCQA since 2014, and my portfolio includes our initiatives around digital quality measures, our research and analysis team, our contracts and grants arm, and our performance measurement team, the ones who develop the measures that you are probably familiar with HEDIS and electronic clinical quality measures.
Thank you, Michael. And Blackford, how about you?
Good afternoon, everybody, and welcome from around the world, I see. It's really incredible. It's a great pleasure for me to be with Michael and Chris and Kat today, as well as thanks to the EHealth team and to Apovida for sponsoring this. I'm the Chief Informatics and Innovation Officer at Apovida, a general internist by training, and I completed fellowship at Stanford way back in the day and started thinking about learning health systems and clinical informatics and trying to connect the dots, if you will, in the knowledge ecosystem, which we'll talk a little bit more about. Thanks all for coming.
Thank you. And Chris?
Good afternoon, everyone. My name is Chris Tignanelli. I'm a trauma critical care surgeon at the University of Minnesota. My research is really focused on clinical informatics, and I specifically use informatics, mainly AI and decision support, as tools to improve the quality of care. My research has been funded by AHRQ, the NIH, and the Gates Foundation. And for COVID-19, my research includes leading multiple randomized controlled trials in COVID and implementing various decision support solutions for COVID-19.
Wonderful. And thank you all again for joining us today. I think this is going to be a great panel. Let's get started with just a general level set. Blackford, why don't you tell us a little bit about the learning health system, what it is and what people should know about it?
Sure, thank you, Kat. And maybe if we could jump to the next slide. One of the things that I think we all recognize in the era of COVID is that the need to accelerate knowledge translation and specification and implementation for use of decision support, as Chris says, and cognitive support at the point of care has never been greater. This has been an assault on our systems kind of like none other, and builds upon, of course, I think the great work from ARA and high tech, getting EHRs installed and standards developed, but never have things been as accelerated as they have been today. The LHS, Learning Health System concept, really came out of a Institute of Medicine workshop in 1984. And in that workshop, they describe a rapid feedback and learning cycle that we built upon for this work today in the COVID-19 guideline effort. The IOM also had a workshop on digital infrastructure for the LHS. And this went further than simply the kind of conceptualization to actually thinking about how do we put the nuts and bolts together to improve the way we treat data, to make data interoperable, and the way we can treat knowledge and knowledge assets to make them interoperable and useful or broadly available in a wide variety of clinical information systems. So I would suggest there's four key bullets, and then I'll turn over to Michael for some comments as well. But you know, when I think about the learning health system, the four essential tenets for me are the following. We need to decrease the time of knowledge translation and specification from new discovery or new knowledge, new learnings, or new experience so that we can use those learnings in practice. It needs to be accelerated, but it can't be too fast, right? We have to have enough time to reflect and review and truly arrive at a consensus. And it can be as fast as we can provide feedback. Without a speedometer of some kind measuring the value and impact of knowledge assets in practice, we can't really say whether or not they're working, and that's a key tenet of the learning health system. So decreasing the time of knowledge translation specification, also ensuring the full life cycle management of composite knowledge assets. What I mean by that is, just like when we're building a Chevrolet or a GM car in Detroit, it's made up of all kinds of knowledge parts and pieces, or technology parts and pieces, whether it's a wing nut or the transaxle or the hubcap, et cetera. And they all fit together because the ecosystem of that automobile supply chain knows what the standards are and what the expectations are across the entire thing. So that's why we can build cars. We're now doing the same thing with knowledge components, so that a composite knowledge artifact, like a complicated C19 guideline that's made up of terminologies and value sets and expressions of logic and whatnot, can be assured to work effectively and properly in practice. This knowledge ecosystem is emerging today. I think the C19 pressure allowed us to do things in a novel approach, which we'll come back to. That is this notion of agile knowledge engineering. Not the old days where we would take a guideline and the guideline itself might arise after 17 years, of discovery and learning. Rather than sort of doing that linear process, we pursued a model of agile knowledge engineering. This is just like the idea of agile software development, rapid iteration, rapid tests, sort of fail fast and get it right. And that iteration and the work that Chris T and others led resulted in this C19 severity of illness and classification algorithm, which you'll hear more about from Chris. So those four things, I think it's the feedback, or rather, hang on, get my notes. The knowledge translation specification acceleration, the full lifecycle management, the ecosystem idea, and then rapid iteration. Mike, what do you think?
Oh, very complimentary comments to what I'm about to say, Blackford. Not surprisingly, you and I have worked together for quite some time. So I'm going to take it a slightly different level, though, and I think together this will really pull it. I mean, I just think about this as a loop of self-reinforcing learning to improve care, period, for people and populations. I mean, that's the beauty of the idea, is that you can both develop and disseminate guidelines based upon real-time evidence generation to close gaps in care and make it actionable. You can have both population level interventions, person-centered or person-specific guidance. And given the data that we're generating in the course of care, not requiring additional data, but leveraging what's already present in our systems, you can actually take information about individuals' unique needs, values, backgrounds, include that in sort of the clinical decision support, and really implement changes in real time faster based upon evidence generated. In this case, obviously, lots of new evidence being generated as people are learning how to take care of patients with COVID-19 and drive those improvements. I'll just say one other thing is that there's an opportunity for better measures embedded within this system too, so that you get reflection of care and gaps at the point of care. At the same time, you're generating more population level type of metrics. And separate and apart, you can have accountability level metrics for value-based purchasing or payment models that are less time sensitive, but leverage the same information. So I'm looking forward to the conversation. I think that's how we're approaching it at NCQA and leveraging what you've described in terms of technology opportunities too. Over to you, Kat.
Thank you. Blackford, anything else to add before we explain what a clinical practice guideline is?
I was so excited to get started. I completely forgot to address the slide. Thank you, Kate. I just want to say in a nutshell, the way we're approaching this at Apovida, and this is not a commercial presentation, but as Michael's already alluded to, we are trying to put together this toolkit and parts library onto a common platform to support that continuous learning in quality measurement at scale, implementation at scale, and learning at scale, to implement clinical intelligence algorithms, routines, pathways that we'll hear more about, and to implement then value-based care optimization solutions. So the neat thing is today, the technology and the knowledge generation and standards and the data standards are really coming together in a way that I've never seen before. It's fun.
Thank you so much. And again, thinking a little bit about folks who may be unfamiliar with some of these terms, Chris, could you talk us through a little bit about what a clinical practice guideline is?
Mm-hmm. Absolutely. If you could actually go to the next slide, we have some information on a computable clinical practice guideline. So computable CPG. But before I start talking about a computable CPG, let's just think about historically how guidelines have worked. And I think this will really lay out why it takes 17 years for a guideline to actually get into practice. Because we've had a very waterfall type approach where it's very linear pattern. You have multiple societies publish a bunch of narrative guidelines. So in trauma, we have 4 US societies that release trauma guidelines, and they're narrative and they're 10, 20 pages long. And then there's hundreds of guidelines. So you got guidelines for solid organ injury, TBI, penetrating chest trauma, et cetera. And now think about it. You have 900 plus US trauma centers, many of which are rural and community based. They have to comb through multiple 10-page guidelines and then make local guidelines based on these, 40, 50 pages for 100 different disease processes. And how are they going to disseminate them? Maybe they, write out their guideline in a 2-page summary and email it out to the group. Maybe for some of the more important ones, they do some presentations on them. And maybe for just a small selection of them, they do decision support. So it's no wonder that we're failing to translate guidelines. It's a lot of work, and it's very linear and it's very slow. So the Computable clinical practice guideline kind of changes things a little. So it has 4 different knowledge layers, and they're called L1 through L4. And L1, everyone's very familiar with. That's your narrative guideline. That's the written recommendation. But then moving beyond just your written recommendation, there's also a semi-structured guideline, which is, and this is something that's actually actionable. So you could have a group of clinical content experts, ideally at the national level, for example, take these 4 or so narrative guidelines from various societies, national and international, and kind of merge those into a standardized operating procedure or a clinical algorithm. And that's really what your L2 is. And in the trauma world, we're starting to do this. So these 4 US societies just a few months ago have gotten together, and around anticoagulation, ventilation management, we are taking these narrative guidelines and making L2 structures with the goal that after that, and actually after is the wrong word, a lot of this can be done in parallel, but kind of after that, you can start converting these into standard compliant guidelines, which include logic in them. It has interoperable standards. You identify what are all the data elements that you want to go into this, and you can start mapping those. And you can also start mapping in the outputs as well. And the benefit of including the outputs is that if you start thinking about a guideline as kind of an application where the decision support system pulls data in for each patient when they potentially meet a guideline, that application can hold on to that information and send those out as case reports so that you can actually build data registries in real time. And the benefit of doing that is you can actually look at the impact of your guidelines in near real time and start seeing where does it work really well, what population does it fail in, et cetera. L4 is just the executable of those guidelines.
Thank you, Chris.
Blackford, Michael, anything else you'd want to add?
No, Chris, I think you highlighted the key, why we're excited about what you described.
Definitely. I am wondering, how do we know that these computable guidelines are as reliable as the other ones that you were describing that can take 17 years to come together? And what's different about these?
One thing that's different and Blackford's muted. One thing that's different and one thing that we did differently with COVID is the guidelines are faster to make. We call some of them clinical consensus guidelines. One of the things that we did to make sure that they're more reliable than kind of the historic, society publishes a guideline and local experts translate those guidelines to our system is we convened a panel, essentially guideline committee of institutions across the country for various COVID guidelines. And the benefit of that is you're not just relying on your local experts, you're relying on a group of 3, 4, 5 different institutions that come together that are considered experts in this topic that review that and then really help with formulating that L2 structure. And that's actually done, we did that in parallel with when the informaticists are sort of coding up and mapping the various different data elements or writing out the logic. And that's kind of that agile approach. Instead of everything being a long linear process, doing multiple things at the same time, defining our process measures at the same time, for example. So I think that's one of the key things is just making sure that it's not just local expertise only, but we really rely on our guideline committee to help develop that. And that also helps with dissemination around your institution and building buy-in, saying that, you know, we worked with these other institutions, everyone's kind of on the same page.
If I might, to amplify something Chris said, which I think is a key point, and hopefully we'll get into in the conversation, is in the pressure-packed situation that the pandemic brought, what Chris described is really a model we should be thinking about going forward, about pulling guideline developers, measure developers, clinical decision developers, thinking with the end in mind, the implementation through a learning health system like this. And I think what often happens is, as Chris described historically, guidelines are developed, then they're passed over to measure developers and the decision support, and you have a sequential rather than a cohesive, collaborative way of looking at this. And I think the lessons I hope we take away from the pandemic that will hopefully help going forward is that collaborative environment that Chris described. I think that's so critical to speedily addressing care gaps, measuring those care gaps, driving improvements, and as I mentioned earlier, using that same process to look at measures that help us with accountability and value-based purchasing.
And Kat, I would add just one other thought. You know, the AHRQ, Agency for Healthcare Research and Quality in this country, is very actively pursuing this idea of a national knowledge platform or a national knowledge ecosystem. And I've had the good fortune of working closely with those folks. But to amplify and sort of underscore what Chris said, you know, variation in measure design or CDS guideline design can occur both in design stage as well as implementation stage. To the extent we can reduce the degrees of freedom, if you will, in what logic I use or what path, what workflow I deploy it in, or what standards for terminology or what data I use, you know, to the extent we're actually drawing from a common parts library, we will have reduced variation, unwarranted variation in design and implementation of these artifacts. You know, imagine if the wingnut supplier from South Carolina was kind of making it up on his own. In a way, that's what's happening, you know, in some ways today.
That's a great point, Blackford. And I'm wondering, given the picture you're all painting of this cohesive technology effort, what are some of the ways that technology can be helpful in creating these new guidelines more quickly and effectively?
And that's for me. Am I starting?
Yes.
Yeah. No, I think Chris did touch on this. You know, the fact that we have kind of all these forces converging at once, that is the installed base of EHR. Thank you very much, American citizens, for high tech in ARA. You know, we have the installed base, we're improving connectivity and interoperability of those data. You know, thank you for the 21st Century Cures Act and the standardization that is happening under fire and with the US CDI. And, you know, thank you to HL7 for CQL and other clinical reasoning standards. You know, the technology convergence has been dramatic. That, coupled with the financial pressures on US healthcare, both to, you know, improve revenue as well as improve quality, and frankly, the whole quadruple aim, I think that has really pressed us along. And on top of all of that, then we had COVID. And this team, the Digital Guidelines Work Group, came together under the C19 HCC, Healthcare Consortium, led by Mayo and MITRE. And it was really an extraordinarily strong effort by a lot of people working closely together. And all of that was technology enabled, of course, not just work from home, but, you know, common work products and tooling that was exploited to make that collaboration work.
So you've talked a lot about how these new computable guidelines are reliable, but Chris, how do you get clinicians who are maybe used to these more traditional guidelines to accept these new guidelines and to accept them and to use them?
Yeah, and I think the most important thing is really making sure that it's a national group of experts that are behind it, as well as medical societies. So that's one of the things that trauma is doing right now. They got 4 different medical societies to kind of come together and merge these narrative guidelines into that L2 format. So kind of getting that stamp of approval, I think, is really important. The other thing I think that is important that we've done when we rolled ours out, we actually have our 12 hospital system is actually on 2 different EHRs. And we actually just recently purchased one of those hospital systems. So they had very different culture, very different practices. And when we rolled out our anticoagulation for COVID, there were a couple of things that they disagreed on. For example, they wanted different anticoagulation ranges, for example. So we actually made sure that the system would be malleable so that it could be tailored a little bit towards each hospital system. So I think that's another thing that you could do to increase buy-in.
I might just add, I think what we learned, at least from measures which are kind of related, is try not to create any additional burden for the practices or the clinicians. Use information and workflows that they have and make them understanding those when the guidelines are written. So again, thinking with the implementation in mind, not just the science. Science is incredibly important. Don't want a guideline not based on science, but thinking about the operational aspect of it, putting it into play, making sure the data are collected in a way that don't disrupt good care, but actually create better care, and then have that data reinforce and learn from that.
And, you know, Kat, the only icing I'd add to the great comments so far is, you know, let's delight the physicians. Let's make clinicians, you know, look forward to using the EHR. I mean, many EHRs have come a long way, but, you know, in my 25 years of practice, a few years back, I want to feel smart. I want to do the right thing. Every clinician does. And it's just hard when there's this tsunami of information. And Chris said it very early on, and it's a subtlety, but it has to be made in a way that fits into my workflow, that is actionable and useful to me, you know, sort of right away, right there. It can't be that I have to go to some other system or some other place to access the latest and greatest. And the only way to keep it updated, as I think Chris alluded to, and Michael as well, you know, is to externalize it, put it in the cloud so that it's EHR agnostic, and all EHRs, all practice sites can be updated, you know, really, really quickly.
Yeah, and to add to that, you know, clinicians, my experience, are really loving the rollout of these clinical practice guidelines. It's making their work a lot easier. It's less they have to comb through. You know, they're tasked with maintaining, you know, maybe 20, 30 guidelines someone might be maintaining. So now if you have centralized guidelines, it's a lot less work on the clinician that they have to do.
Make it easy to do the right thing, right, Chris?
Mm-hmm. Yep.
Yeah.
That makes total sense. And you touched on this a little bit, Chris, but I am curious what you see as the next logical area to explore for new clinical guidelines to build on the success that you've been having.
So in COVID specifically, the areas that we're expanding in is really this concept around long COVID or PASC, post-acute sequelae after COVID. So we're starting to define PASC, and there's no formal definition of it. And then we're going to start building decision support systems around predicting who has PASC, and then also kind of start laying the framework for once we identify what optimal treatments are for people either at risk of developing PASC or who have PASC, to start delivering decision support to bring those guidelines to the physicians at the point of care. That's kind of, in COVID at least, one of our biggest focuses. Our other one is on vaccine distribution, to make sure that we're using appropriate models to most equitably distribute the vaccine to those that most need.
Wonderful. So, Michael, I want to switch gears a little bit to talk about accountability and quality of care. How can those factor into these guidelines once we establish their efficacy?
That's great, Kat. Thank you. We're starting to think about, and I'm sure others are also, sort of quality improvement or measures for quality improvement, somewhat separate from, not necessarily, but could be separate from accountability-oriented measures. So for improvement, we need insights at the point of care that are clinically relevant, timely, actionable, some of the words that Chris and Blackbird already used, and also that are patient-specific or person-specific based upon their unique circumstances. And that's where the clinical practice guideline, evolving as it does through the learning health system, can actually, in real time, provide that kind of insight, and the data being generated can be used to populate a measure that's a performance indicator to drive improvement at the point of care. Those are sort of system or granular decisions that really help close gaps. They're important. Some of those could be accountability-oriented measures. In other words, you lift up and now you aggregate data from multiple patients. Like, how is this system or this clinician or this practice performing and we should attach some payments to it. But that may not necessarily be the case. The data could still form a substrate, maybe on a less timely manner, for an accountability measure that looks at utilization or cost or long-term outcomes. They're related but not the same, and starting to think about where the data reside for those kinds of measures. At the clinical level, you can have more clinical data, less claims data, less sort of the cost data. At a plan, a purchase, or others, you can have that cost data. Ideally, you could access both and kind of look at the best hybrid approach to measure development that takes into account quality and cost and reflect that for accountability as well as for improvement. But as we're thinking now, I'm starting to think more along the lines of quality of care at the point of care, actionable guidance from a CPG that evolves through the learning health system, and accountability measures, again, leveraging the same information, different timeline, corporate cost information that flowed up to those who want to use those for accountability. Be really curious about what Blackford and Chris have to say about that, but that's kind of how we're starting to think about it.
Yeah, Michael, we are in deep sync, and it's no accident, I'm sure. You know, and the other part of the question, Kat, which you didn't say explicitly though, is really issues of equity, right? Why is it Jack Wenberg back in the day, small area variation analysis found, you know, whopping practice differences between New Haven and Boston in coronary artery bypass grafting surgery, and it was really unexplainable. And equity is such a hot topic, and I mean this very, very sincerely. But I would hope that through this kind of work, as Michael's just described, you know, we can be sure that the right knowledge is available to each and every point of clinical decision making in an equitable fashion. So there is no unwarranted variation, which still is a huge problem.
Thank you so much for saying that, Blackford. Chris, do you have anything to add?
I was going to say I completely agree with the comments that were made. You know, one of the issues that we see in trauma critical care is just failure to deliver appropriate care. And we just published a paper last year looking at variation in guideline concordant care across majority, mixed race, and minority hospitals. We saw significant variation with less delivery of guideline concordant care at minority hospitals. And I think the clinical decision support has been shown to improve equitable delivery of guideline concordant care.
I want to add one thing though, because we segued into a little bit of equity and health equity, or inequity as it might. I think one of the big challenges, and I would challenge all of us to think about collecting the data to drive sort of the guidelines. Sort of there are gaps in our data around race and ethnicity and all the different risk factors we'd like to take into account when we start driving improvements or trying to reflect back to drive improvements. So that's you know, we can develop. I'm sure Chris and Blackford and all those who are tech can write the guideline and look for the data, but if the data aren't there to help us understand the stratifications and where the opportunities are to drive improvement, and honestly to commit resources to support that improvement, then we might have great aspirations. But please, we need to get the data in the system so we can start doing this kind of work.
Absolutely. We've heard that in the COVID-19 vaccine response, for example. Yeah, that's a great point. Before we turn it over to the audience Q&A, I did want to ask all of you, what's surprised you about working on these? What has been your experience? Blackford, maybe we could start with you.
Well, you know, I in a way, I saw my dream, you know, be less of a nightmare and actually more of a dream. That we could actually work quickly, work effectively, work with world-class teams and experts on both measurement and clinical practice issues with Michael and Chris respectively. And, you know, sort of see this idea coming to life. It's regrettable. It required a C-19 push. I think we were on a slow boil, if you will, to, you know, sort of see these ideas get adopted. But this was a perfect, you know, maelstrom, if you will, or, you know, a pressure point that allowed us to do unbelievable work in very short order. And it's not in a small part due to the leadership of folks like Chris and Michael in those respective areas, but it's great to see technology play a supporting role.
Yeah, Blackford, you stole the words right out of my mouth. I mean, in our system, we have been talking about completing the learning health system cycle using computable clinical practice guidelines since 2017 or so. And it wasn't until 2020, March, April, with the COVID pandemic that we finally we're able to really pull together and do this and complete the cycle in a number of different projects.
And from the NCQA perspective, I'll say this has really sort of helped us rethink how we want to approach measures, the collaboration, the clinical guideline developers, decision support, the technical people, EHR vendors, the community. We created a digital measurement community. We're trying to facilitate some of these collaborations because, again, think with the end in mind, revisit how we create measures, look at the data, look at the workflows. We're learning a lot from the experience of others. I can't claim to be in the trenches like Chris and his team, but learning from them and making sure that we account for what they have learned in that environment and reflect that in what we do and how we do the work we do to help improve care.
Thank you all so much. And now we're going to turn it over to some audience questions. I've been seeing some great ones come into the chat. So maybe we could get started with, can you comment on the use of critical analysis or evidence frameworks such as GRADE in the context of learning health systems and executable guidelines? Michael, maybe you can take this one, or?
Oh, I want to ask one of my technical colleagues.
Oh, sure.
I can talk about GRADE if you want, Blackford.
Jump in, Chris.
So one of the key pieces that we ran into early on in COVID was, how do we evaluate all of this different evidence that's coming out? And one of the things that we did was we partnered, University of Minnesota has an ARC evidence-based practice center. And the ARC evidence-based practice center worked with the clinical content experts to apply the GRADE evidence to decision framework to take the various pieces of literature as they're coming out, primarily around anticoagulation. That was one of our early use cases, to really develop a guideline that we felt, that they felt, and the guideline development committee felt was the best representation of the evidence that was available at the time. And then the other thing that they did was they continually reapply the GRADE evidence decision framework at various intervals. I believe it was about 3-month intervals. And that actually resulted in changing the guideline itself. It's on its 4th iteration right now. So as new evidence came, they kind of added that back in, and then they worked by committee to refine that. And then that got translated into our clinical decision support system. And then we were able to kind of evaluate the impacts of those modifications on care. So for example, anticoagulation in COVID, we initially in the first pass didn't give it to ICU patients. Now we routinely give anticoagulation to all ICU patients, for example. That was in response to a publication that came out of Mount Sinai that was eventually added into that analysis. So I do think that there's not just so much the piece of just building the guideline and kind of letting it be, but kind of having a framework to continuously reevaluate that evidence that's there. If you think about what happens historically, when I was kind of laying out historical guidelines, some of the guidelines on the web pages, for example, for trauma, have last been updated in like 2005 or so. So it's really important that you have a cyclical process to kind of reevaluate the evidence. And GRADE evidence decision is what our ARC EPC uses. I'm not an expert in that framework, but that's the one that they prefer to use.
And the only thing I would add, Kat, I think, GRADE is excellent. And to Chris's point, we need to have that cyclical iterative process the same way there, as we do in the data side. I mentioned the data side because I believe evidence synthesis in the traditional fashion, needs to be complemented by real world evidence assessment and machine learning and derivation from AI via AI methods, complementary decision support constructs that, fit with the evidence or extend it or maybe even refute it. But it's going to be a combination of real world evidence and those methods of AI/ML with the traditional methods of evidence synthesis like GRADE or the EBM on Fire work of Brian Alper and company, or the evidence ecosystem of the Magic app folks. And, all of these methods still, though, need to plug in, if you will. In the end, it has to be computable. And that's the goal.
That's a great point. So another question from the audience is one that maybe you could speak to, Chris, which is a concrete example of a computable practice guideline and how a provider could readily access it would be really helpful. Could one of you provide that?
Sure. So a concrete example of like a CPG that we rolled out previously, for example, perhaps. So I guess I can talk about anticoagulation then. So for COVID for anticoagulation, there was emerging evidence that identified that patients with elevated D-dimer might benefit from anticoagulation. We had early reports from China in January where they were actually anticoagulating all patients with COVID. We had no evidence here at the time until an early report came out showing that patients receiving anticoagulation had improved outcomes. And that's where a bunch of experts kind of got together. So Stefan Moll at UNC, Surbi Shah locally, Nigel Key, a bunch of sort of experts in hematology kind of got together, and they worked with ASH and started to map out what a potential tiered approach to anticoagulation was. So it was really a consensus clinical practice guideline. And that was mapped actually almost immediately into more of an L2 type framework. So it had logic that went in, essentially, if patients, D-dimer over this threshold, recommend this dosage, for example. In parallel to that being done, so in the agile approach, the decision support informatics team already was mapping out all the data elements. So they said to the content expert team, what are the potential data elements you think might be important in this? They're like, well, you're going to need to know their D-dimer, you need to know if they're in the ICU, you need to know their BMI for dosing anticoagulation, you're going to need to trigger orders for heparin, Lovenox, et cetera. So they could already start mapping those using LOINC codes or RxNorm or whatever you needed using various data standards. And then the logic piece was written in. So that was, once the L2 was kind of done, then they could start writing the logic for how those different data elements worked. And then in parallel, it was mapping out, well, what are we going to track? What's our outcome? What are our process measures? So all of that was written in at the same time. And then that system, once it was kind of done, we piloted it just at one hospital. And typically we'll do a full pilot. We'll typically do a usability event. We'll make it out in a playground environment. We'll do a formal usability test with end users and a heuristic evaluation. Then we'll optimize it. Then we'll roll it out in a pilot. Then we'll do some form of re-aim evaluation about 1 to 2 months after. Then we'll scale it. COVID, we didn't have time to do that. We piloted it, and 10 months later, we scaled it. So that's kind of what happened in COVID. And then we did iterative 3-month planned evaluations. And I think we're on the 9-month evaluation now.
Wonderful. Thank you, Chris. So next
I could add a quick thought,
oh, sure.
Kat, if time allows.
Of course.
I think the challenge is that we've seen many publications of successful guideline implementations in EHR systems at one system after another. The idea, though, of developing a new guideline at the Brigham and sharing it to Chris or sending it to Chris to use, up at Minnesota is what we're really overcoming here today. Apovida has implemented, a number of different knowledge artifacts, and we're building out this capability on the platform now for shareable clinical intelligence. We did a bunch of experiments with the CDC, for example, building out a gonorrhea guideline that could be shared across multiple EHRs. And, docs love it. It's, gonorrhea can be hard. I won't go any further. But the whole idea is to be able to share these assets, so we all don't have to reinvent the wheel.
Yeah, I would almost, one way, and it's not exact, but one way that you could potentially start thinking of these guidelines is almost like a small program. And that program, I could email it to Blackford, or I could have it here, but it receives information. The logic is built into it. It sends information back to your EHR that you could receive using your standard FHIR API, for example. And then you could provide decision support, workflow integration, however your system likes to do that, for example. And that's how I really am starting to, or I try to describe this new wave of computable guidelines. And then the other benefit that I hinted at before is because it's receiving all those data elements. So they say, what are all the things you need me to map? Are they in ICU, et cetera? It can pull information the next day, for example, like, well, what were the outcomes? Did people follow this or not? And now that app has everything. It has all the stuff that went in. So it can take them, make that a row in a spreadsheet, and export out a registry for you. And now you could, 2 days later, after a patient came through, you can start looking at what was the impact of that guideline on that person. And that was one of the biggest things that we really did with this, with the COVID clinical practice guidelines that we initiated, is we built a database that updated every day at 9 o'clock in the morning, allowing us to instantly look at, yesterday, who came in that met, criteria for this guideline? Did they get it? What were their outcomes, et cetera?
And Chris, I imagine the room there is to also package in an executable quality measure, both for improvement, that was improvement one, but also sort of the accountability, same sort of the same package, distribute it with the guideline and the CDS and so on.
Absolutely.
Yeah, we've touched on this a bit, but one person wanted to ask more explicitly, how does this learning health system or computable practice guideline affect consumer health?
Well, I'll jump in, but I'll ask colleagues to help me out. It's an excellent question because really, value has to be perceived ultimately from the patient's perspective, whether you call it a consumer, a patient, or citizen, what have you. Certainly, there's been a lot of work done on shared decision-making. Imagine if the patient and the provider had the same knowledge asset, and they're both working from the same knowledge base, if you will, perhaps in different ways, but really working together in shared decision-making or pursuit of shared goals. I think one day our guidelines will not only be reflected to all of our providers and healthcare delivery team, but also to the patient. So a patient can help to define their goals and update their goals and document progress. So immediately the benefit to the consumer is that they get better care, reduced error and better care, hopefully at lower cost. Long term, I think the consumer can be much more engaged and activated. Frankly, an activated patient is the best way to activate a doc.
Building on what, I'm sorry, Chris, go ahead.
Oh no, you go for it.
I was going to say, building on what Blackbird said, there's back to some of the earlier comments about leveraging data that's very person specific and sort of these clinical practice guidelines and the measures and so on. But there are also some comments in the questions about sort of remote patient monitoring and sort of incorporating those into the activated person, the person who's generating data as they walk and live and breathe and do their things. That could be incorporated into this whole LHS and modeling and improvement and tracking. So very complementary. Go ahead, Chris.
And Mike, you recommended, you mentioned the word personalized. I think that's one of the other things that we can really start doing. Instead of a one size fits all guideline, you can start giving more personalized recommendations right to the provider for their patients. So for rib fracture patients, this is actually what my K award was on. We built a care map for treating patients with rib fractures. And we had an automated system that stratified patients into mild, moderate, or high risk for decompensation. And patients received personalized care, somewhat personalized care, based on which bucket they fell into. So it wasn't just so much just a standard, everyone kind of gets an epidural or whatever for pain management. It was really, is this person failing IV opioids, for example? And then they get that recommended treatment.
Yeah. Some of the research we're doing at NCQA, our team, not me, is around goal attainment. So you set very person-specific goals, document those, and you measure on an individual basis whether the person is moving towards their goal or not. And so that's the individual personalized aspect of the measure. But then for the systems, is the population as a whole moving towards their goals? And the insight that they're generating is that these kinds of conversations about person-specific goals are not routine, as you might imagine. And when they do happen, the people, the patients really respect them. And the clinical teams really feel like this is a relevant conversation to have that we never had before. Now, getting into the workflow, getting it part of sort of the guidelines, get it part of the data that we generate to do, that's sort of the next challenge. But in terms of a concept, Chris gave a very specific one, but this is more generic, very, very specific to a person, but generic goals, because you can't specify specific ones in a guideline about somebody who wants to be able to walk 3 times a week, right?
And I think another piece too is patient safety. I think that you can really improve patient safety using these systems. And to give a specific example again, one of the things we did was we had in the rib fracture decision support, it pulled patients' creatinine and gave a recommended gabapentin dose, for example, based on creatinine, and it either did or didn't recommend NSAIDs, for example, based on their creatinine. So it was very automated in that fashion.
You know, Kat, and one other thought, boy, this is fun. You know, you asked earlier, what else should we be thinking about with respect to computable practice guidelines? Well, you know, my suggestion would be everything, but let's define the universe, right? We only have solid evidence, according to Brent James and others, for maybe 25% of what we do. But let's make sure we get that part, you know, that right. And then for the rest of it, let's create the learning health system so no matter what we're doing, we're learning from, you know, kind of each patient N of one contributing to the body of knowledge.
Now let's start with the guidelines that Chris referred to that are old, out of date, that are really important and relevant, and sort of start working on those in the new model that we've been describing. That would be a good start too.
Absolutely. We only have time for one or two more questions. And I did want to ask, maybe Chris, you could speak to this, or Michael, are patient-reported outcomes being used to inform LHS activities? And if so, how?
Well, the goal attainment scaling would be a type of patient-reported outcome. It's not as structured as the PROMs, but certainly that's part of it. I let Chris and Blackford talk about whether there's an actual example of that in the learning health system. But go ahead, gentlemen.
You go for Blackford, then I can go after.
Well, you know, the patient-reported outcomes probably have more. I mean, every patient visit's now followed up with an HCAP survey, and you know, we do all of that. And that's a lot about patient experience. I'm not so sure it's so much about clinical outcomes yet. Payers, however, are becoming increasingly interested in patient-reported outcomes for clinical reasons. That is to make sure that, you know, the right interventions are happening. And I think that'll drive more patient engagement. It's still kind of a pain in the neck, you know, to do as a patient. But, you know, when it's more relevant to my daily life and whatnot, you know, I can log my footsteps or I can log my diet. I can log some stuff for a patient-reported outcome.
Yeah, so we're collecting PROMs. We're not necessarily using them just yet. So for the rib fracture example that I gave, we use this app called Get Well Loop, and we send patients various surveys. So the PROMIS dyspnea survey, the SF-12 functional status survey, at various time points after their hospital disposition or discharge, a month, 2 months after, 3 months, et cetera. And right now, all we're doing with PROMs is really just collecting it. Ultimately, what we could do, though, is look at the association of various guideline adherence or various treatments on those PROMs. Because right now, what we look at is what's the impact on length of stay, discharge, disposition, death, in-hospital complications. So it'll be really interesting to start looking at the association on longer-term outcomes that matter most to patients. And then we can start tailoring treatments to really optimize PROMs. I think you're going to see this in COVID. Once we start defining paths and we start looking at what is the long-term outcome from the respiratory standpoint, for example, after COVID, we may be reevaluating a lot of these medications. For example, I ran a clinical trial of losartan in COVID. It's hypothesized that COVID could increase TGF-beta and you might get more fibrosis in the lungs. So maybe we find out that losartan doesn't work, and I don't know, but maybe we find out losartan doesn't work acutely to reduce hospitalization or reduce mortality in COVID, but now you have who has long-term outcomes, who has long-term shortness of breath. You might find, oh, this drug actually does prevent that in the long run. So now you may have kind of a redefining of what practice recommendations are. So right now, though, we're really just in the collecting PROM phase.
Well, thank you so much, everyone. We're just about out of time here, but I do want to thank everybody for joining this panel. Michael, Blackford, Chris, this has been an incredible discussion. We could easily go on for another hour, I'm sure, but again, thank you so much. And Jen, back over to you.
All right. Well, thank you everybody for joining this afternoon, and we hope to see you next week at some of our programs. Have a wonderful day.
Thank you, everyone.
Thank you.
Thanks, Kat.